All right, a very good afternoon to everyone. So today we have our 11th series on Icon Amrita E-Gurukul, and we have a very exciting lineup today. We have Dr. Reena Nair, we have Dr. Anant Gokarn sir, and we also have Dr. Alok Shetty, who's a dynamic speaker. And to introduce our today's session, I will call upon Dr. Pravas Mishra sir, who is the program director today. So Dr. Pravas sir is a consultant at Amrita Faridabad. He's a professor in Department of Hematology and BMT. Over to you, sir.
Thank you, Dr. Karan. This is wonderful. So this is our icon E-Gurukul, and like all our E-Gurukuls, we take up a focused topic and have an in-depth discussion on that. And for this today, the topic is drugs and lymphoid neoplasms, and I would like to invite Dr. Anant Gokarn, who is the professor of the Department of Medical Oncology at Actric Tata Memorial Center, Mumbai. Um, Over to you, Dr. Anant.
I thank the organizers for having this event and giving this wonderful platform for students to learn. And without much ado, I will request Dr. Alok Shetty. I'll introduce Dr. Alok Shetty to start his topic for today. And I would also introduce the mentor, Dr. Hasan, who is an associate professor in United Institute of Medical Sciences at Prayagraj. And the speaker for today, Dr. Alok Shetty, who is a dear colleague and an associate professor in the hematolymphoid DMG at Tata Memorial Center. So Alok, it's the stage is set for you to for your topic.
Alok sir, you're muted.
Yeah, sorry. Yeah, thank you, Anant. Good afternoon, everyone. So I'll start off. I'll share my slides, my screen. Yeah. Is this visible, Karan?
Yes, sir, it's visible and you're audible. Thank you.
Yeah. So I'll start off. Okay, good afternoon, everyone again. So I think I've been asked to talk on drugs in lymphoid neoplasm. Quite a big challenge. I mean, lymphoid neoplasm starts from A and ends with Z plus. So I was just thinking how to justify and cover these few topics. So this is an old article, almost from an article in 1999, published in NEJM. Where they've looked at classification of lymphomas and lymphoid neoplasms based on the cell of origin. So interestingly, I think I'll be talking from before the germinal center. So I'll be talking on drugs used in ALL and drugs used in CLL only. I think we have another lecture next week or so where I think Hodgkin lymphoma and drugs used in NHLs will be covered, other NHLs. So today I'll just stick to drugs used in ALL and drugs used in CLL. So moving on. So I think this is roughly the format that I'll use. So I'll be talking on the mechanism of action of the drug, briefly on the metabolism, dosing and administration, and with focus on adverse effects. I've kept it as brief as possible to, so that we can cover in the stipulated time. And also any further questions, there are also further, I think, questions with an examinee. So I'll have to finish on time. So I've kept it as brief as possible. With respect to one thing to remember with respect to drugs used in ALL protocols is that there is a general principle irrespective of which protocol one is using in one center. The principles being that it's a multi-agent chemotherapy. These different drugs are effective in probably different parts of the cell cycle, making them non-cross resistant. The chemotherapy that needs to be used needs to be dose intense. That is, these drugs need to be cycled at regular and frequent intervals to cause effective cell kill. And an important part of ALL protocols is CNS prophylaxis, which could be by the utilization of drugs which have CNS penetration, either systemically, like with high-dose methotrexate, or by delivering the same intrathecally. So these are the general principle of any ALL protocol that one uses, whether one is using hyper-CVAD, whether using BFM-based protocol, UKLL protocol. These are the general principles that they follow, that which make these protocols more effective and different from a lot of other solid tumor protocols. So with respect to how these different drugs are used, so for example, daunorubicin would probably be more effective in the S phase, vincristine in the M phase, prednisolone in the G1 or G2 phase, and cyclophosphamide, which is an alkylating agent. So these different drugs are cycled at regular intervals and given repeatedly to cause an effective cell kill. So there are different phases of therapy. The first being the induction of remission, then there's a consolidation of remission, an M protocol, which could be the high-dose methotrexate could be part of the protocol or used otherwise separately. If one goes by the principles of the BFM protocol, where re-intensification or delayed intensification had shown significant benefit, and maintenance, of course, in ALL, which is, I think, the flag bearer of utilization of maintenance in most leukemias, is the ALL. So where one gives prolonged low-dose therapy to decrease the risk of relapse. So moving on to the drugs individually, the first drug, and I'll talk about, is vincristine. So vincristine, which is very interestingly derived from the Madagascar periwinkle. So the mechanism of action is it inhibits microtubule formation, very similar to taxanes, but not the same. Similar, but not same. So basically, where you have microtubule, which it prevents the it binds to the tubulin dimers and prevents aggregation of these tubulin dimers to prevent formation of microtubules. So basically, it inhibits microtubule formation. So it inhibits the polymerization or prevents the aggregation of these dimers. Taxanes, on the other hand, actually prevent the depolymerization. So that's something interesting to remember. So in simple terms, it inhibits microtubule formation. Metabolism, so it is predominantly metabolized in the liver, and also you should remember that it is the circulating form is albumin bound. These have little clinical implications, with that being with the underlying liver disease, there could be higher risk of toxicities because of vincristine, and also low albumin or hypoalbuminemia may predispose to vincristine toxicity. That is one. The second being the drugs which also affect these cytochrome P450 mechanism, that is, which could be either inhibitors, could increase vincristine levels, thereby increasing the risk of vincristine toxicity. So that becomes the clinical significance of knowing the metabolism in this case. Administration, it is an IV administration with dose around 1.4 mg per meter square. An important thing to be careful about with vincristine is the risk with extravasation. So one needs to be wary of that. And an important difference in vincristine extravasation is that one needs to utilize warm compressors while dealing with vincristine extravasation, or with any other vinca alkaloids, in contrast to most other agents where one uses cold compressors. The important or primary adverse effects of vincristine being peripheral neuropathy. This again is because of its same mechanism of action, which would affect neuronal transmission, neuronal pathways. Autonomic neuropathy, which could cause symptoms such as constipation and ileus. SIADH and hyponatremia is an important. So this is almost like a triad of vincristine toxicity, where there is peripheral neuropathy, ileus, and hyponatremia. And interestingly, the way pediatric population or children tolerate vincristine is not the same with that in adults. You will realize that with time, that with age, the risk of vincristine toxicity actually increases because of either lower metabolism. So the incidence of peripheral neuropathy, these ileus, hyponatremia, is much severe in elders compared to the pediatric population. So when you're using the same ALL or pediatric inspired protocols in either AYAs or in elderly population, you will see these toxicity more often and in more severe forms. So you'll need to be more careful. Another interesting being jaw pain that is seen after vincristine injection, and rarely other than hyponatremic seizures, vincristine by itself is supposed to be a risk factor for seizures. So these are the important adverse effects. Remember, all very important adverse effects. It's not just in ALL, vincristine when used anywhere, even as part of RCHOP. So these are the adverse effects one needs to be aware about. That is vincristine. The next would be daunorubicin. Again, an important anthracycline, which when used with vincristine is an important component of induction of most ALL protocols. So here, daunorubicin, like any other anthracycline, it inhibits topoisomerase 2, thereby affecting the cell cycle. It also leads to formation of free radicals, which can in turn lead to cell death and cell kill. It is metabolized in the liver, that is undergoes hepatic metabolism. Therefore, any underlying liver injury could aggravate daunorubicin toxicity. Administration is IV. An important factor while administration, like always, is the risk of extravasation, like with all other anthracycline, whether doxorubicin, epirubicin. So one needs to be careful or wary about extravasation with daunorubicin when being administered. And here one would use cold compressors, unlike in vincristine. Lastly, moving on to the adverse effects, very important adverse effects which lead to high risk of induction mortality. One is mucositis. So high risk of mucositis, which will lead to breakage of the mucous membranes, which will lead to increased risk of fungal infections, increased risk of gram-negative sepsis, which translocate from the gut. So mucositis is an important adverse effect of daunorubicin. Though interestingly, if one is comparing, say, daunorubicin or doxorubicin, the incidence of mucositis with daunorubicin is supposed to be lesser and less severe compared to doxorubicin. Which is the reason why daunorubicin is there in induction and doxorubicin is there in reinduction or delayed intensification, is that being the reason. Next being cardiotoxicity. I'll just come to a slide for that, and myelosuppression. These are the important. So cardiotoxicity, like in all anthracyclines, so even with daunorubicin, with cumulative doses being around 400 to 550 mg per meter square, with or without the presence of risk factors. So one needs to be careful about what doses of doxorubicin or daunorubicin have been used, more so when one is following these patients for a long time, and also when one is planning treatment at relapse. Another important drug of which is a part of most AL protocols is L-asparginase. So L-asparginase is important drug, and even single agent L-asparginase has a significant activity in ALL. The mechanism of action being these lymphoblasts of ALL are basically defective in the production of L-asparginase by their own because of epigenetic silencing, and because of which they lack this enzyme called L-aspargine synthetase, which the normal cells would have. So they are essentially dependent on plasma L-asparagine, unlike the normal cells. So this L-asparginase, when given, would convert the L-aspargine to L-aspartate, which cannot be utilized by the lymphoblasts, thereby leading to cell death of these lymphoblasts. Interestingly, one is that it has lesser activity in pH positive ALL and would probably just add to toxicity, because of which in pH positive ALLs, L-asparginase is typically omitted. Metabolism, it undergoes hepatic metabolism. Administration, it can be administered either IV or IM. Also, importantly, a pegylated form is available, and which can be given. The frequency of dosing could be reduced with the utilization of pegylated form. There is at least either the based on where this enzyme is derived from, either from E. coli or Arvenia, there are different formulations. So the classic E. coli which one uses is has to be administered once in 3 days or twice weekly at a dose of around 6,000 to 10,000 international unit per meter square. The pegylated, on the other hand, can be given once in 2 weeks. So that is the pegylated form. Similar to how I mentioned in vincristine, the tolerance of L-aspargine in adults is much lesser compared to the pediatric population. So the risk of adverse effects, the degree of toxicities are much higher in the elder population compared to L-asparginase. So actually, if one even while reading, you'll realize that the biggest challenge of utilizing pediatric ALL protocols in adults or even the AYA population, the major challenge is this L-asparginase. So because of which a lot of these patients have a hepatotoxicity which sets in usually towards the end of induction, which can be very problematic, which can be prolonged, which can delay any delivery of further therapy, making it a big challenge. So but that's good to it's important to remember that even AYA, even elderly do not tolerate L-asparginase as well as pediatric population or as well as children. So the important adverse effects of L-asparginase being hypersensitivity, because it's a protein. So hypersensitivity, this is an anaphylaxis which can happen while administration. Hepatotoxicity, which is very important, usually may start off with mild just hyperbilirubinemia and hypoalbuminemia, which usually progresses to transaminitis and a cholestatic hepatitis like picture. Thrombosis, this is again because of the depletion of L-asparginase, which impairs synthesis of antithrombin 3. So there is increased risk of thrombosis. So either DVT or more commonly one sees superior sagittal sinus thrombosis, or basically just central venous thrombosis, which can happen with the utilization of L-asparginase. Pancreatitis, relatively rare though, but is another important adverse effects of L-asparginase. Hyperglycemia, so is another important adverse effect of L-asparginase, again because of L-asparagine depletion. So this hyperglycemia which happens would actually compound the hyperglycemia that is happening with the utilization of prednisolone during induction. So these are the important adverse effects that one definitely needs to remember with respect to L-asparginase and while utilizing them in during ALL induction. The next drug that comes in utilized in ALL is cytarabine. So this again, very interestingly, the doses and the way it is utilized in ALL is quite different from the way it is used in AML. In cytarabine, at least in the pulses or legs that are administered in ALL, at a dose of around 75 mg per meter square per day over 4 days. So by the mechanism of action, so it's basically a pyrimidine analog, and basically it affects with the cell cycle in the S phase by its analogy to other nucleosides. So it's a pyrimidine analog. It is metabolized in the liver. It can be administered IV or subcutaneous with, it's usually administered in what we've called as pulses or legs over 4 days in usually in the second phase in consolidation. The adverse effects, mainly when utilized in ALL, the primary adverse effect being neuropathy. So one needs to be careful while administrating these pulses of cytarabine in consolidation, and myelosuppression. So these are the important adverse effects of cytarabine when used in ALL. With respect to high dose cytarabine, which is used in AML, where it's on the other polar end, where doses are to the range of around 9 to 12 gram per meter square or more, one would commonly the expected adverse effects being cerebellar toxicity, chemical conjunctivitis, which warrants utilization of prophylactic steroid eye drops like prednisolone eye drops, and a flu-like syndrome, described more commonly in pediatric, though can be seen in any group, where one has during the cytarabine infusions, one can have fever, myalgias, fatigue. So that's a classical flu-like syndrome of high-dose cytarabine. So that's the 3 important adverse effects of high-dose AML, which high-dose cytarabine, which is also good to revise during this point of time. So that is cytarabine, which is given along with 6-mercaptan in the phase 2 of induction. The next most important drug is methotrexate, which is utilized in various forms actually throughout the ALL protocols. In simple words, it is an inhibitor of dihydrofolate reductase. That is, it prevents the formation or the conversion of DHF or dihydrofolate to tetrahydrofolate, and thereby inhibiting thymidylate synthase and thereby inhibiting the cell cycle. So another good to remember that time, it's in the same a pathway that even the GI drug of 5-fluorouracil comes into play, though at a different time point. Important, at least over here, good to know that there is leucovorin. The way it is utilized in GI is much, or the way it is, the mechanism of action of leucovorin is different here. Or when one gives it as leucovorin rescue, it is basically to restore active folate stores in the host cells, thereby to reduce the toxicity that can happen with this dihydrofolate reductase inhibition. So that becomes the side effect of that is with respect to leucovorin rescue that is given with high dose methotrexate. So important to remember that methotrexate undergoes hepatic metabolism, but a large portion of it is excreted via the kidneys. So hepatic metabolism and renal excretion, clinical significance being that those both with liver dysfunction, patients with liver dysfunction, patients with renal dysfunction, one needs to be careful about their metabolism. So the dosing and administration, so doses more than when given infusionally, doses more than 500 mg per meter square are referred to as high dose methotrexate. So that amongst of all drugs in lymphoid neoplasm, one needs to remember that drugs with systemic CNS penetration is one is high dose methotrexate, the other is high dose cytarabine. So high dose methotrexate refers to doses more than 500 mg per meter square. Of course, the doses are much different when given as orally. It can be given intrathecally also, which is what one does during induction, where if one is CNS positive or CSF positive, one gives it weekly till clearance, till the end of induction, and thereafter 2 weekly. Or if one is negative, one gives intrathecal methotrexate 2 weekly, which is at a dose of around 12 mg. Then oral methotrexate, which is given during maintenance. So this is given weekly once, and that is oral methotrexate. So this is overall, this is about methotrexate. Important to remember is a high dose this is again the metabolism, where you have it is metabolized predominantly in the liver, but excretion is predominantly in the via the renal system. So adverse effects. So this is something I use. The adverse effects of high dose methotrexate in a head to toe fashion. So things can start from leukoencephalopathy. So this you would typically see around 3 to 14 days post infusion, where patient can come with headache, dizziness, confusional state, and then even focal motor deficits, which are usually transient and self-resolving in most cases. The common, many things have been tried to see if they have any major benefit, things like aminophylline, things like some syrups which contain a drug, sorry, I'm not getting the name, which can also be used to reduce the effects of this, but none of them have shown very significant benefit. But the good part being about this leukoencephalopathy being that it is usually self-resolving. Dryness of eyes, redness of eyes is another common thing that you would see while utilizing high dose methotrexate. Mucositis is a common feature of high dose methotrexate used wherever. Pneumonitis, though pneumonitis is actually much more common in case of with oral methotrexate than actually with high dose methotrexate, interestingly. One thing important to, since we're at the lung, one thing important to remember with respect to high dose methotrexate is that one needs to be careful about third spacing or presence of effusions, ascites, which could lead to increased high dose methotrexate toxicity. So whenever you're admitting a patient for high dose methotrexate or planning high dose methotrexate, ensure that the patient does not have a gross pleural effusion, gross ascites, all of which would lead to delayed methotrexate clearance and increased toxicity. Nausea and vomiting can be present, which would again, it would increase the cycle of delayed methotrexate clearance, dehydration, delayed methotrexate clearance, and toxicities. Diarrhea can happen because of similar mucositis. Hepatotoxicity is a feature. Nephrotoxicity and tubular injury is a feature of high dose methotrexate, and one of the most dreaded complication of high dose methotrexate toxicity. And just like all other drugs, most other drugs that we declared, the tolerance of high dose methotrexate in adults is not as well as compared to the pediatric population, again making it a challenge of delivery in this population. Myelosuppression can also happen, and skin rash, skin pigmentation and exfoliation. This is many times seen predominantly over flexural areas like groin, axilla. So skin pigmentation and exfoliation is another commonly seen adverse effects with high dose methotrexate. So these are the adverse effects of high dose methotrexate. So moving on to the next drug, which is used as part of uh, maintenance therapy and also in consolidation and reintensification with other drugs, is 6-mercaptopurine. So compared to cytarabine, which is a pyrimidine, this is a purine analog, thereby affecting the purine pathways and cell cycle in the cell cycle and DNA synthesis. It is predominantly metabolized in the liver. The main interesting thing to remember, or important clinical feature to remember with respect to the metabolism, is the role of these enzymes, which are TPMT and NUT15, which play a pathway in 6-MP metabolism and degradation. So these have there are a lot of heterozygosity in the presence of in how this amongst the population with respect to TPMT and NUT15, leading to differences in metabolism of 6-mercaptopurine. So those who have certain mutations in either TPMT and NUT15 can have decreased metabolism of 6-MP, thereby leading to increased toxicity, increased cytopenias. So, that's one thing. There are different strategies one uses for this. There are some probably centers where they consider preemptive testing, that is all patients undergo. Some centers utilize it only, or testing is done only if one sees toxicities. So good to remember TPMT and NUT15 mutation testing for 6-MP to identify metabolizers who have a different metabolism of this drug and thereby have a higher risk of toxicity. Administration can be given orally, either tablets and even syrup formulations of 6-MP are available. The main adverse effects being myelosuppression and hepatotoxicity. So these are the factors that you would monitor when the patients are on 6-MP, which is CBC and LFT. So good to remember this. So that covers most of the conventional drugs which are utilized in ALL. I will just touch upon two novel drugs which are utilized in ALL, which were initially utilized in the relapsed refractory setting, and things are moving up to the frontline more and more commonly. So two drugs. One is the antibody drug conjugate. It is inotuzumab ozogamicin. So this is an anti-CD22 antibody, with the drug conjugate being the payload being ozogamicin. So it targets CD22 in the lymphoblast and delivers ozogamicin, which in turn causes cell death. And this is a calcium product like most other payloads. So this is classically recommended or utilized in the, I think, in two settings. One is one can use it in the relapsed refractory setting, or in refractory setting where somebody is flow MRD positive, one can use it for clearance. Also, one can utilize in elderly patients who are otherwise unfit for any intensive induction. This can be utilized. So these three settings where one can use inotuzumab. The administration is intravenous, where it is in cycle 1 to a dose of around, cycle 1, it is given to a dose of around 1.8 mg per meter square. Divided doses, usually day 1, day 8, and day 15. Cycle 1 is usually counted around 21 days, and cycle 2 onwards is 28-day cycle, where one gives 1.5 mg per meter square. It's available as a 1 mg vial. So this is about inotuzumab. Adverse effects, the major adverse effects of inotuzumab ozogamicin being hepatotoxicity and veno-occlusive disease. So one needs to be careful. There are recommendations to utilize prophylactic ursodeoxycholic acid, or UDCA, when patient is receiving inotuzumab, to decrease the risk of hepatotoxicity and to decrease the risk of veno-occlusive disease. That's why if a patient is where if inotuzumab is being used as a bridge to transplant, it is suggested that not more than 2 cycles of inotuzumab are given prior to proceeding with transplant, because anything more than 2 cycles would increase the risk of veno-occlusive disease post-transplant. Veno-occlusive disease post-transplant, as we know, has like high mortality and high morbidity. So utilization of ursodeoxycholic acid when patients are receiving inotuzumab osagamicin. Second being hypersensitivity reactions while administrating inotuzumab. So using appropriate pre-medications and monitoring before the administration of inotuzumab. So this is inotuzumab osagamicin, a drug being used more and more often. I mean, with also because of its efficacy, because of its availability, ease of administration compared to the next drug, which is blinatumomab. So blinatumomab, on the other hand, is a BiTE, where it is an anti-CD19, anti-CD3, bispecific T-cell engager. So it engages CD19 on the B cells or the B lymphoblast, along with CD3, which is present on the T cells, and release of interleukins, interferon gamma, perforin, and granzymes, which leads to apoptosis and cell death of the neoplastic cell, which is the B lymphoblast. So that is blinatumomab. In brief, it is a BiTE. So administration, on the other hand, in contrast with inotuzumab, where it is a short duration of infusion, this is an intravenous infusion which is given over days together. So I'll just skip to this. So the dosing of blinatumomab is actually dependent on the body weight and the BSA. So in those who are less than 45 kg, it is a BSA based dose, wherein induction in cycle one uses day 1 to 7.5 microgram per meter square per day as a continuous IV infusion, and then day 8 to day 28 at 15 microgram per meter square per day. And cycle 2 onwards, it's around 15 microgram per meter square per day, our continuous IV infusion. On the other hand, in those who are more than 45 kg of weight, it is given as 9 microgram per day continuous IV infusion day 1 to 7, followed by 28 microgram per day from day 8 to day 28 and in further cycle. So a body weight based dosing, and most importantly, it being a continuous infusion and needs to be given by an infusion pump, which makes it the biggest challenge. And the other being the adverse effects one needs to be aware about is cytokine release syndrome and neurotoxicity. Though, of course, like in all cases, the cytokine release syndrome will be dependent on the burden of disease and which cycle. So in somebody who has high blast percentage end in cycle 1, the adverse effect of the risk of CRS is much higher compared to someone who is probably just an MRD positive disease. So blinatumomab, similar to inotuzumab, is being utilized in patients who are MRD positive for MRD clearance, can be used in the relapse refractory setting, can be used as frontline therapy in also patients who are ineligible for intensive induction. For example, like a D-ALBA study, which studied in patients who are pH positive, where just TK and blinatumomab showed excellent response rate and excellent survivals also. So this is another drug, though I think availability is a big challenge still in India, but I think being used more and more often. Okay, so that covers, I think I've covered most drugs in ALL. I'll be covering some of the most commonly used drugs in CLL, which would be bendamustine, venetoclax, and BTK inhibitors. So in CLL, the age-old drug, which is bendamustine, which was studied in the STILL and BRIGHT trials, one in Europe and one in the US, which became the landmark drug or the standard drug for all low-grade B-cell lymphomas or low-grade BNHLs. It was bendamustine. So this is an age-old alkylator, which causes intra and interstrand DNA crosslinks, leading to cell death. So good to remember that it is an alkylating agent. It is metabolized via the liver. The administration is always IV. Important adverse effects that one needs to remember are rash, tumor lysis, that is in patients who have high tumor burden to begin with, either a very bulky node, high cell counts in patients with CLL, massive splenomegaly. So these are patients who would be at high risk of tumor lysis in the first week, of course, when bendamustine rituximab is used as a regimen. Cytopenias. So cytopenia is predominantly neutropenia or lymphopenia is an adverse effect that can be seen with bendamustine, which is usually a little delayed and not the usual day 10 to day 14 neutropenia that one sees. There is always being an alkylator, there is always a risk of secondary malignancies with bendamustine. Also, good to remember this time point of is that bendamustine would also affect T cell collection or cause T cell depletion, making it, sometimes if one is utilizing it repeatedly, or repeated challenges of bendamustine may affect T cell collection for CAR T or other procedures. So this is bendamustine. The doses being either 60 mg per meter square or 90 mg per meter square, and it's a 28-day cycle when used with rituximab. That is the bendamustine plus rituximab regimen. The next drug, which is vitamin V or venetoclax, which is used, which actually showed exquisite or very great activity in CLL, is venetoclax, though I think I missed the E. So venetoclax. So the mechanism of action being, it's a BCL2 inhibitor. So BCL2 is overexpressed in these neoplastic B cells, which is, it's a pro-apoptotic protein. And when venetoclax is administered, it inhibits this BCL2 and overcoming this inhibition of apoptosis and causing cell death. So that is the main action of venetoclax. The two main conditions where it has major activity is CLL, and the next being AML. So importantly, the metabolism, it is metabolized in the liver, and importantly, it is metabolized by the cytochrome P450 enzyme pathway. This is utilized both as, one needs to be careful while using drugs such as azoles, where inhibition of the cytochrome P450 would lead to increased levels of venetoclax. Though this is being used as a what I say is jugaad, where you give azole so that one can use lower doses of venetoclax, thereby using it as a cost-effective method. So important to remember that venetoclax, when utilized with these CYP3A4 inhibitors or inducers, would affect venetoclax levels. Administration is oral. Very important to remember with respect to venetoclax dosing in CLL is that one needs to consider ramp-up dosing. This is because of the high risk of TLS that one would see with venetoclax. Again, a very interesting thing is that how TLS varies in varied points of time with respect to disease, if one considers. So the risk of TLS with when one is comparing AML and CLL, so the risk when venetoclax is used in CLL, the risk of TLS is much higher, or the degree of TLS is much severe when used in CLL compared to in AML. Similarly, the risk of the same different drugs for the same disease, like for example in CLL, the risk when one is giving venetoclax based regimens is much higher compared to when one is giving bendamustine. Anyway, that's just something interesting. So good to remember, important to remember that a ramp-up dosing is needed when venetoclax is being administered for a patient with CLL. And this ramp-up has to happen over weeks. Unlike in AML, where one doesn't have time and the risk of TLS is much lesser, where ramp-up, if needed, needs to be done over days, the ramp-up dosing for venetoclax in CLL needs to be done over weeks. So this is, people can use different regimens or different ways of ramping up the dose, but it needs to be gradual. So this is one of the proposed ramp-up methods, where you give 20 mg in week 1, 50 mg in week 2, 100 mg in week 3, 200 mg in week 4, and 400 mg in week 5, and if needed, further escalation. So that's the usual ramp-up dosing for venetoclax. So important to remember two adverse effects. One is tumor lysis, and which can happen. So one needs to be careful in patients who have high disease burden, and the other being myelosuppression, though the severity of the myelosuppression that one sees is not so severe in CLL compared to AML. Okay, the last and the an important drug in CLL is BTK inhibitors or Bruton tyrosine kinase inhibitor. So BTK is an important intracellular molecule which has important roles in B cell receptor signaling. So these BTK inhibitors essentially inhibit this essentially inhibit this Bruton tyrosine kinase and thereby affecting downstream pathways and interfering with B cell receptor signaling in the a neoplastic cell. So the generations of BTK Is have come in, with the first being ibrutinib and next being acalabrutinib, and now more recently we have drugs such as zanubrutinib and pirtobrutinib. The differences being that these have different side effect profile, or the risk of side effect profile is different in these different drugs. It undergoes hepatic metabolism. Administration is oral. Adverse effects, I think very important to know while administering these drugs. Though oral, they are not free of adverse effects. These arthralgias, rash and diarrhea, usually manageable, less life-threatening. So arthralgias, which can usually involve large joints and sometimes even small joints. So there's an important adverse effects. Rash, which can be present like most other targeted therapy, and diarrhea. So these are some otherwise manageable adverse effects and less life-threatening. More life-threatening, or one of the most significant risk, is cardiovascular effects, most commonly hypertension and arrhythmias. So one needs to be careful about this. So either monitoring of blood pressure for patients who are on these drugs, and also discussing the risk of arrhythmias. Usually atrial fibrillation is the most commonly implicated most common arrhythmia that happens in these patients. So at least a pulse examination for these patients and ECG monitoring is an important thing to remember while giving these drugs, though the risk of cardiovascular adverse effects is much lesser with more later generation of BTK inhibitors, but it is not nil and always needs to be discussed. Another is infections. So an important infection that is specifically attributed to ibrutinib is supposed to be aspergillosis. So there's a risk of infection. Also, there is a bit of T cell dysfunction, owing to which one needs suggested administration of drugs such as acyclovir as prophylaxis and cotrimoxazole as prophylaxis in these patients. So these are some of the important adverse effects of these drugs that one needs to be aware of. Sorry, another one which I've not mentioned is bleeding. So there's always a risk of bleeding in these patients. You need to be careful, especially if the patient is on anticoagulant therapy for any other indication. So you need to be aware of that and discuss that and plan your therapy accordingly based on that. Right. So these are the adverse effects of this. So thank you. I think I finished on time. So finished. Yeah. Yeah. I think I just remember that the drug which has shown some efficacy in methotrexate leukoencephalopathy is dextromethorphan. So I just remember that later. Yeah. Okay. Yeah. Thank you. So I think finish.
So thank you, Alok. Thank you for the wonderful talk. I mean, you have excellently summarized all the important drugs, in very short time, and you covered most of the points that is required to be known before handling and using these drugs. So thank you for the wonderful talk. Now we will, I think there are a few questions on the chat box. I think we can take those. So there's one anonymous question on re-challenge of high dose, whether we can re-challenge high dose MTX if there is encephalopathy.
Yeah.
So I can take that. I think re-challenging high dose MTX encephalopathy is really is an uncommon but very severe kind of side effect of high dose MTX, and patients become very miserable. Sometimes have hemiplegia, altered mentation. Although thankfully it is reversible, somebody goes through such a difficult problem, I would be really very in re-challenging high dose MTX, and I would not really re-challenge with high dose MTX. We generally tend to use other drugs like high dose Aracip, somebody which also has a good CNS penetrating effect. So if you know the MCP 841 protocol has actually a high dose Aracip based uh, regimen for CNS prophylaxis, so that can also be used. So it no, I would really not re-challenge. So next question.
Anant sir, can we take the examination first and go on to the chat box after that, sir, please?
All right, okay,
Thank you
we
so
can
much.
do that. So yeah, so I think Reena ma'am, can we start the examination? We have, I think, the student who uh, has he joined? I think I cannot see him online.
Yes, sir, I have joined, sir. Good afternoon, sir.
Okay. So, good afternoon. So, Reena ma'am, can we start the questions examination?
Yeah, sure. Can you see the slides?
Yes, ma'am. Yes, ma'am. I'm able to see now.
Okay. So, yeah, Raghu, I think the lecture which Alok has taken has answered all the questions. And I am grateful to Alok for sending the questions as well. So, the first is a patient who's 35 years old with BALL. And on day 18, he presents with constipation and pain in abdomen. And his bowel sounds are sluggish. And when you do an X-ray, this is what you can see. So, Raghu, how will you decide which is the drug that is to be implicated? What is the differential and the diagnosis in this patient? How will you manage this patient? And then gradually we'll speak on other toxicities.
Okay. Good afternoon, everyone. Good afternoon, ma'am. As per the history, this is a patient of BALL on induction therapy. Uh, in the abdominal erect X-ray, we can see multiple air fluid levels clearly seen. So the most probably implicated agent might be vincristine over here, as it is a part of the induction therapy regimens. Uh, yes, ma'am. And the most probable implicated agent will be vincristine, and the management will be one is we should give proper boil rest and give a NG, keep the patient NPO, and uh, we can insert a Riles tube and keep on the NG-dependent drainage, and yeah, ma'am, and we can wait for the effect of the vincristine to wear off, and can yes, ma'am. Then we can give prokinetic agents as well here.
So,
Hello, uh,
so
Dr. Reena. Ma'am, requesting if you could please make it full screen in the presentation mode, please, ma'am.
one, it's okay. Sorry, it's not on full screen. Is it okay now?
Yes, ma'am.
Okay. So, Raghu, you said you will manage conservatively. Is there any indication other than conservative? Suppose this patient doesn't improve, then what will you do?
Um,
More than 90-95% patients will be fine at the end of 2 or 3 days. But there
yes,
will be occasional patient, and during this period, what will you look for?
well, most probably this is a case of paralytic alias secondary to vincristine. Usually this is self-limiting, man.
Yeah.
If at all it doesn't improve, then we have to repeat an abdominal X-ray after 2 to 3 days. We have to look for air under diaphragm, man, and to rule out perforation. And if there is evidence of perforation, then we have to do exploratory laparotomy. Surgical exploration has to be done.
And is there any preventive surgery that you can think of in these patients or maybe indicated in these patients? When you do the repeat stand-up X-ray or you do a sonography of the abdomen. So generally, if a patient is, the patient starts running fever, has any problems, then you start thinking of bowel ischemia. And at that point of time, you will need to get your surgeons inside. And a preventive measure is something that they measure is the cecal wall dilatation. And that gives an idea that if some kind of prevention and preventive surgery can be done. Otherwise, yes, 95% of the patients improve with the management that you have said. What are the other toxicities that you know of which vincristine can cause in your patients?
On infusion, there can be extravasation associated. Then other toxicities can be peripheral neuropathy, predominantly motor neuropathy, and also autonomic dysfunction in the form of postural hypotension, or as we saw in this case, in the form of paralytic ileus.
Okay. So can I ask you whether it is motor or sensory neuropathy, which is much more common? How do you grade the neuropathy and how do you adjust the doses of vincristine for patients who need to take it in their ALL protocols?
In the case of vincristine, a motor neuropathy is more commoner than the sensory neuropathy, ma'am. And the grading of neuropathy, grade 1 will be mild tingling and numbness in the basically tingling and numbness sensation in the extremities. Then grade 2 will be mild functional disability in the form of like
Okay, so you'll do the grading and the reading. Basically, you have to be really careful when it's grade 3. You have to be careful because anything beyond that will be totally debilitating to the patients and it is irreversible when you get foot drops and hand drops. So don't wait for something like that to happen. Okay, the next is, this is a spotter for you. You can see the second slide, the hand of this patient, 30 years old, on induction, presenting with swelling and redness over the right palm, noted soon after receiving her chemotherapy in the daycare. She comes to you in the OPD. What will you do?
Ma'am, this is probably a case of extravasation, secondary to anthracycline, maybe daunorubicin, or it can be due to vincristine as well. As we heard earlier, the immediate management would be if it is due secondary to daunorubicin, then we have to give a cold compression and flush the IV line as soon as possible. And if it is severe, then we can also try to aspirate the drug from the with a syringe. In the case of vincristine, we have to avoid cold compression and we have to give a warm compression. And in the case of severe, if there is severe compartment syndrome, then we have to go for a surgical intervention in the form of fasciotomy.
How do you classify the drugs which cause extravasation?
The most commonly implicated drugs will be anthracyclines and the vinca alkaloids. The most commonly implicated
Vesicants, and then the remaining would be irritants and non-vesicants.
irritants.
Any antidotes or some drug that you can apply locally or otherwise use in either vincristine extravasation or in adriamycin or an anthracycline extravasation?
I'm not 100% sure, but DMSO can be applied in the case of doxorubicin, the anthracycline extravasation.
Yeah.
For vincristine, I'm not sure.
Okay, there's something known as hyaluronidase.
Yes.
Yes. Okay.
Yes.
All right. So the next question is, one second. Sorry. So this 40-year-old patient with BALL on induction presents on day 28 with complaints of headache. Since one day followed by an episode of convulsion. After the clinical examination and basic labs, an MRI is done. And this is the MRI picture which you can see. Which among the drugs that you have used for your ALL induction therapy do you think is the agent which will be implicated, and how will you manage the patient when this patient comes to you with an MRI like this? Basically, what are the?
Is it, ma'am, it can be a case of, ma'am, it looks like a cortical vein thrombus, maybe post LS Perginis. I'm not too sure, ma'am. Or it can be post intrathecal methotrexate chemical meningeal, electromeningeal enhancement leading to the chemical meningitis post methotrexate, intrathecal methotrexate, ma'am.
So, Alok, will you like to say what happened to this patient?
Yeah. So, hi. Yeah. So this is more likely CVT or superior, it's, cortical venous thrombosis, which is there. Intrathecal methotrexate, not very commonly that you will see chemical meningitis, and you will see more diffuse meningeal enhancement if you're talking about that. And the MTX encephalopathy is actually much more common in high dose methotrexate, which you will see later in the M protocol. But here, most commonly, patients were vomiting, some form of dehydration, a little elderly, like in this case, who has high risk of LAS toxicity, you would consider a CVT because of LAS. So many times another mistake that happens is one says patient comes with headache, you attribute it to post intrathecal headache. But if it is happening for more than 48 hours, even, and has some other localizing signs, always think of possibility of CVT.
Okay.
So what are the other toxicities that you encounter with Lunase?
One is hepatotoxicity initially in the form of hyperbilirubinemia, then later can manifest as transaminitis. Another important adverse effect is acute pancreatitis and the thromboembolic events.
So are there any cutoffs to
And
say that, at this triglyceride level we will continue, and when will we stop, or at any point where you say that at this amylase level we will hold the drug, and beyond this we will not give Lunase to this patient? So are there any such graded toxicities where you actually take a decision on stop, hold, let it revert to grade 1, or stop completely for pancreatitis and for hypertriglyceridemia?
I'm not completely aware, but triglyceride level, the cutoff is 1000 milligram per deciliter, and above that we should hold the Lunase, and we should manage it and let it come to a norm within the range. And amylase lipase levels above. No, I'm not 100% sure.
Okay. But if a patient has a severe pancreatitis, will you consider continuing with Lunase? Is there an alternative, or will you stop and not use it even in re-intensification?
And we can re-challenge it in re-intensification. We should hold it in the during the induction. We should not give it further. We should hold it during the induction phase.
Just a little bit of the regular Lunase that we use versus the pegylated. What are the differences? What is the route of administration? How often do you give? What is the half-life approximate?
E. coli classical L-asparagines, it is given via intramuscular or the intravenous route once every 2 to 3 days, twice per week. It should be given, and the pegylated form should be given once every 2 weekly. the dose is different. For the classical L-asparagines, the dose is 5,000 to 10,000 international units per meter square, and for the pegylated pegylated asparaginase, the dose is 25,000 international units per meter square. Not with the
Okay. Any other complications can you remember, or
infusion reaction, hypersensitivity reaction.
yeah, hypersensitivity? And when you're giving it with steroids, what worries us most?
Not okay. Hyperglycemia, the shooting up of blood sugars.
Yes. Anant, how much time do we have? Because I'm sure there are many questions from the audience also. So the next one is,
Ma'am, we have couple of, we have couple of minutes. We have almost 45 minutes. You can go ahead, ma'am.
oh, okay. So the next patient is a 35-year-old patient diagnosed to have BALN post-induction with the BFM protocol. He is MRD negative. He is in the first phase of his consolidation, admitted for high-dose methotrexate. How will you take care of this patient as far as planning for his methotrexate dose? What will you do during the time that he's getting his methotrexate? And how, before discharge, what all will you look for?
Ma'am, before starting high dose methotrexate, we have to take care of certain checklists. First of all, we have to see his hydration status, then the general condition, then the liver function, renal function, the cardiac function. We should get a baseline ECG and an echocardiography to rule out any volume overload conditions. Then other than that, we have to check the electrolytes, the levels of the electrolytes, mainly sodium, potassium, and magnesium. Uh, when all the checklist is done and it is the patient is acceptable to be given the high dose methotrexate, then we have to pre-hydrate the patient with the 5% dextrose or half NS. We have to add potassium with that and the soda bicarb infusion to alkalinize the urine. The pH, the acceptable pH will be more than 7. Urine pH should be more than 7, at least for more than 4 times consecutively, and it should be monitored throughout the infusion every 2 to 4 hourly. Then we have to the high dose methotrexate should be started. It is to be given by covering the infusion set and as well as the tubings with aluminum foil because it is supposed to be photosensitive. The dose of high dose methotrexate in B cell ALL is 3 gram per meter square. It is to be given over 24 hours. Initially, a bolus, 10% dose of bolus should be given within the 1 to 2 hours, and the rest of the 90% of the infusion should be given separately over the next 23 to 24 hours. Then we have to check the level of the methotrexate in the blood at the end of infusion, that is 24 hours from the start of infusion. And we have to start folinic acid rescue. Folinic acid rescue is the first dose is given immediately at the end of the methotrexate infusion. The dose will be 50, 15 mg per square meter. Then we have to check the methotrexate levels, one at 24 hours post starting, then at 42 to 48 hours, and another after 24 hours. And the folinic acid rescue should be continued till the every 6 hourly, till the methotrexate level comes below 0.1, sorry, less than 1 millimoles per liter. So
okay, suppose you are alkalinizing a patient and you don't achieve the pH. Is there anything else that you can do?
we have to increase the dose of soda bicarbonate. We cannot start the methotrexate before the urine is alkalinized completely.
And in somebody who has alkalosis and inadequate alkalinization, is there any drug that we use? You continue alkalinizing, but is there any drug that you can use?
Oral sort of like a low doses.
Okay. Acetazolamide can be used in these patients, right? Why do you want to alkalinize the urine in patients before you give methotrexate? What is the concept behind that?
Ma'am, the methotrexate, it gets denatured if the urine is acidic. If the urine is acidic, then the methotrexate molecule gets denatured and it loses its activity.
Yeah, precipitated. It is not
Yes.
soluble in patients who have very acidic. Okay, Alok, any more questions you want on high dose methotrexate?
One thing is, Raghuram, you should always check for drug interactions, which can potentially potentiate the toxicity of methotrexate. So drugs like pantoprazole should not be given with methotrexate. So pantoprazole is something that many people use in inpatient or patient setting, but this is contraindicated for methotrexate. Similarly, NSAID. So checking drug interactions is very important, which can lead to the toxicity of methotrexate.
Any food restriction, not for high dose methotrexate, but otherwise when you tell patients during their maintenance and they're using methotrexate, any instructions that we give to the parents or children to time the methotrexate doses?
One is high citrate containing foods and especially fruits should be avoided as they are acidic in nature, and red meat should be avoided.
So they say don't give it with milk. I don't know if it still holds, but that is what we used to keep telling all the kids, not to take it with milk. So all the time for methotrexate was in the evening, 2 hours after they had had their milk. Is there anything like any preservative that is used in the methotrexate that we use?
Ma'am, in the intravenous formulation, there is a preservative used, the benzyl alcohol, that helps to it prolongs the shelf life of the methotrexate. If the if the preservative is not used, then it cannot be used further more than 2 to 3 days. But this preservative is not used in the intrathecal formulation. That is preservative free.
Preservative-free preparations are for intrathecal and when you are giving the high dose over a long period of time. Okay. So this is what happens next. Again, a BALL patient, MRD negative, has taken his high dose methotrexate, and then he is brought to the casualty post 5 days with complaints of mild weakness of the right upper and lower limb. And he has hemiparesis, and this eventually resolves quickly. Which is the drug which you would implicate, and what would be your management, and what are the CNS toxicities of high dose methotrexate, the entire spectrum of them?
Ma'am, as he is receiving the hydromethotrexate as part of the interim maintenance protocol, the implicated agent would be methotrexate. This is probably a leukoencephalopathy post high dose methotrexate, which has manifested as hemiparesis. Uh, we can starting on like this is due to increased intracranial pressure. So to relieve his intracranial pressure, we can give him like, mannitol or 3% NaCl or and uh,
So here it is typically a diagnosis where it has resolved by itself very quickly. So what would be, do you think it is leukoencephalopathy or it can be something else?
I'm not getting it.
something known as press is a possibility.
Oh, yes, present posterior reversible encephalopathy syndrome.
Okay. So yeah, treatment we don't know. Some people say give steroids, it will at least decompress. I'm not sure if mannitol is still used. Mannitol was used a lot in our times. It generally reverses by itself. Um, are there any genetic predispositions in acute leukemia to patients developing leukoencephalopathy or neurotoxicity when they are on high dose methotrexate?
UDP, the patients who are basically they're deficient in the conjugation enzyme of the UDP glucuronide transferase.
So some genetic predispositions are GWAS, GSPP1. There are some, and the MTHFR patients are much more susceptible to developing neurotoxicity when they are on high dose methotrexate. It would be important for somebody who's getting recurrent problems with high dose methotrexate. Anything typically on the MRI that would suggest this is, what are the findings on the MRI that would tell you this is methotrexate induced neurotoxicity? Okay. So it is basically hyper intense mostly, but it can be anything from a normal MRI to something that has complete, which shows actually including affects the myelin-rich matters, which happens in leukoencephalopathy typically. So you see a wide variety of changes in the MRI, and they would all suggest from normal to the end. So then if we come to the maintenance part of these patients, the drugs that we commonly use are 6-MP and methotrexate. And so for a patient who's in response with the normal counts, no nodes, and no organomegaly, how would you manage a patient who is asymptomatic, has low counts with an ANC hovering around 1,000, and is otherwise absolutely fine? You'll be happy with the dose you are giving? Will you reduce the dose or will you make any changes in the dose of MP and methotrexate?
Ma'am, as the patient has low counts, this is probably secondary to the 6 mercaptopurine. We will hold the 6 mercaptopurine for 1 week, and we will restart the 6-MP at the same dose the following week after rechecking the counts. And
so what is the ANC that you would like to maintain during maintenance therapy? Is it the regular total count of 4,000 and ANC over 2,000, or is it a lower range of ANC which actually tells us that the outcomes will be better?
the minimum, at least the counts, the ANC should be at least 1,000.
Alok, do you have any suggestions for this patient?
Yeah, so I mean, you need to achieve adequate myelosuppression. So anything ANC more than 0.75, that is more than 750 or 1,000, and platelets more than 75,000 or 1 lakh is also acceptable. So like ma'am was referring to, it's not the usual doses like while giving chemotherapy. You need to achieve a bit of myelosuppression and monitor these patients to achieve these these levels of ANC and platelets without having any hepatotoxicity. So that needs to be kept in mind while delivering maintenance therapy to these patients.
So Raghu, what will you do for the second patient? Now his ANC is at 3,500 and his total count is 5,100. You're happy to continue with the same dose, or will you like to change the dose? And is there any, that I will ask Alok only, is there any recommendation how you increase the doses of 6-MP?
Yeah, so I think, I mean, recommended is some around 20% a dose increase of 6 mercaptopurine. And you would ideally like to see them after 2 weeks with the repeat CBC and LFT and then decide, but go slow again and yeah, with monitoring. But 20% dose increase with each step is what is recommended.
And so if we maintain at about 500 to 1,500 ANC, we are happy, and then we don't increase the dose any further. So again, on maintenance, you have this patient who has counts which are reasonably okay. ANC is maintained. It's come with mild nausea, and the enzymes are slightly elevated.
So, ma'am,
Level
as we
with
can
you
see,
allow the enzymes to be elevated without worrying about changing in the doses. And if at all you want to change the dose, which drug will you change?
as we can see, there is a grade 3 transaminitis sale. There is grade 3 transaminitis, so we would like to first hold the six mercaptopurine for at least about 1 week, and then again restart with a 10% reduction in the dose of the 6 MP.
Alok, you want to?
Yeah. Yeah, so I mean, hepatotoxicity is again sometimes a little dose limiting. Though methotrexate may be slightly more hepatotoxic compared to mercaptopurine, but both are equally. Like you said, we would probably in this patient, we would want to interrupt and restart once the liver enzymes are at least less than 200. So it's a balance of the counts and the liver enzymes in these patients, or hepatotoxicity in these patients.
So up to 4 times the upper limit of normal, we are happy. We don't worry. Once it starts going beyond that, then we need to take a call on, especially if the patient is becoming symptomatic. And so you have the next patient. I think Alok has already given out the answer for this. You have an asymptomatic patient with the count that is okay. It's 500 ANC. Platelets are 40,000 and the rest of it is okay. What do you like to do?
This is the MCV is high, so probably due to a folic acid manifestation of the methotrexate probably toxicity, ma'am. So we would like to interrupt the methotrexate for 1 week and recheck the CBC. Also hold the 6 MP as it can further, that also can further cause myelosuppression, and recheck CBC after 1 week and then reassess.
Yeah, your
Then
platelets are also low over here. So we would like to be more careful in this patient. Alok, anything else?
So yes, ma'am. So the same, and like Raghu, you highlighted, maybe you'd like to check nutritional parameters like vitamin B12 and folate. But if you're not able to check, maybe supplement them and follow up these patients. Yeah.
And the fifth patient is fever, back pain, 2 weeks. Total count is quite good. What will you do?
So the case of febrile neutropenia, so we have to interrupt the dose of both 6 MP and methotrexate, and depending on the grade of febrile neutropenia, uh, we have to give antibiotic support, and we have to wait for at least 1 week and recheck the CBC counts, and then we have to do a dose reduction, at least a 10% dose reduction of both 6 MP and methotrexate after the infection is cleared off.
Anant, Alok, any
So,
suggestions?
Raghu, anything
Raghuram, see,
in this?
between patient 4 and patient 5, there is slight difference. Like here, the total count is really good, 5,000, but the neutrophil count is unusually low. So the question that would be in my mind is, the total count is 5,000, the neutrophil is only 200. What are the remaining cells? So I would be worried about cancer coming back in this case, whether there
Oh,
is a relapse. So I would actually, you are right that we have to treat the fever, we have to give antibiotic, but also I would ask for a manual differential count to see whether there are blasts in the peripheral smear, because I would be really worried because of the high TLC, matlab normal
yes,
TLC and a low ANC in this case.
Yeah.
yes,
Yeah, so that's what. So any patient with cytopenias, like I think everyone's first fear is whether this is a relapse
relax.
happening. So especially many times people come with this low grade fever, vague back pains. So, of course, sometimes they may have new onset nodes and organomegaly, but always think whether this could be a relapse before, you're just adjusting the doses of 6 mp and methotrexate.
Yes.
Anant, are there any more questions on ALL? We
So,
can finish those
so
and then
there
we go
are
to CLL.
questions in the chat box, ma'am. I think we can take a few. I had taken one question before
Sure,
this.
go ahead.
There are few questions, and I think we can do. One question is by Astha Parmar, that why is there more chance of TLS in CLL with venetoclax as compared to AML? And I think
Okay, I think we are
Alok had.
coming to that. If there's anything on ALL, we can finish off first, maybe.
So ALL is one was the re-challenge of high dose MTX. The other question is, can we give PCI after high dose induced encephalopathy? Ma'am, would you want to take that question?
After,
If somebody has high dose MTX induced encephalopathy, would we give PCI or Alok, anybody?
Yeah, I mean, we've given I mean, PCI after high dose, after leukoencephalopathy. So I think there's no contraindication as such. And regarding the previous question, regarding re-challenge of high-dose methotrexate, also like Anant sir said, it's a little scary to re-challenge high-dose methotrexate. Though I think our pediatric department has tried it and they've not found too many toxicities again. But again, it's a big challenge. So you can proceed with PCI after high-dose if you're using it in your center as prophylaxis. No contra.
So one question comparing syrup with the tablet. So what are the long-term outcomes of syrup 6MP is the question. So previously we did not have syrup 6MP. Now with we've got syrup Preval that is available, and uh, although we do not know the long-term outcomes, the pharmacokinetic studies show that the levels are quite well maintained and the myelosuppression is quite well maintained. So there is no reason for me to fear that the long-term outcomes will be any different. At least that's what my opinion is. Ma'am, do you want to say
uh,
something about the syrup formulation?
I have given up on pediatric leukemia treatment, I think 30 years back. That was the first 2 years of my training in TMH, so I'll leave it at that. Raghu, before we wind up ALL, uh, some idea about what are the prophylaxis you take during induction and during maintenance? Is there any difference? And how do you adjust the doses for patients who are on, 2.5 years of therapy or more than that? So what are the drugs that you would use for prophylaxis in these patients?
One is during induction, they are on hydrosteroids. So we have to give PCV prophylaxis in the form of Cetran DS uh, twice per day for 2 days per week. And also we have to give antiviral prophylaxis in the form of acyclovir, 200 mg twice daily. Also during if we are giving a hypersevere based treatment, then we also have to give fluconazole 200 mg twice daily. But these have to be we have to be very careful before giving vincristine. We have to hold the azole at least a day prior, and also if you are during high dose methotrexate, the Cetran DS has to be hold for the previous week. And
So I'll ask
yes,
Anand, what is the actual dose of acyclovir for prophylaxis? 200, 400, 800 BD?
So in BMT setup, there is a trial comparing lower dose with higher dose prophylactic acivir, 200 BD versus 400 TDS, and lower doses are also equally effective. So although we continue to use 400 TDS, even lower dose 400 BD or 200 BD should be uh, equivalent. So as long as Asivir at least 200 BD is ongoing at that should be enough. But we continue to use in 400 TDS, which is the traditional dose of Asivir in our ALL as well as BMT patients. But lower
And
doses
you
have
will
been
continue
used.
during maintenance also, or it is only during the high dose chemotherapy until consolidation maybe?
So we do not continue. We only give Septran prophylaxis during maintenance, ma'am.
Maintenance.
Unless somebody has had the herpes, if somebody develops herpes, then we give it for at least a severe prophylaxis at least for 1 year to prevent recurrence of herpes.
Now look, when we are adjusting the ANC between 0.5 and 1.5, how careful will you be with Septran, or you are comfortable in continuing Septran throughout the maintenance?
Yeah, I think I would be comfortable continuing it only, ma'am. I think others leads to unnecessary interruptions, though there is again little thought whether the Septran by itself is contributing to little myelosuppression, but I've continued it and it's okay.
Okay, since we don't have steroids in this part of the treatment, should we really worry, or
Yes, I think there's still a significant risk of PCP that can happen because of maybe
maintenance?
cell activity being suppressed and lymphocyte activity being suppressed by the 6-mercaptopurine and methotrexate. So there is definitely risk. So one needs to consider.
Raghu, did we miss any drugs for acute leukemia? Yes, positive.
In the case of pH positive ALL, then the TKIs will come, TCR will TKIs.
Okay, so which one will you like to use if a patient is pH positive upfront? You have all the finances with you.
Dasatinib, second generation TKI, dasatinib.
Alok, any thoughts on that?
I think people are now thinking of using ponatinib, I think, which is coming up. So if all resources, I think ponatinib is the go-to drug currently. But if not, then dasatinib would be the next choice.
Any chemo-free regimens for elderly patients, Raghu, in induction? pH positive, like ALL in elderly. You don't want to use chemotherapy at all. All the drugs are terrible. Okay. You just heard one drug, right? We also discussed the other drug. So I don't know if Anant will tell us. There was a study with inotuzumab, ponatinib, and maybe steroids. Is that something that we would consider for elderly, or it's too risky to have such inductions?
I personally have not used it, ma'am, but that is one of the regimen. The other regimen is to use a mini hyper CVAD, that is a low dose of hyper CVAD with inotuzumab. These are the two regimen that have been used. We have used a low dose regimen hyper CVAD with inotuzumab for a few elderly patients, but they are very, very toxic. So even that low dose can cause a lot of prolonged cytopenias. But these are the options that are available.
Okay, so Anant,
They
you want to
are,
take the CLL questions from the chat box first, or should we go on with?
yeah. Ma'am, maybe we can finish the examination questions. There are not many CLL questions in the chat box.
Okay. So Raghu, you have a 65-year-old gentleman diagnosed as CLL. The fish shows 17 p-tail. In view of progressive anemia and thrombocytopenia, you want to treat this patient, and so you started ibrutinib. And about 2 months later, the patient comes with this ECG. So what are the side effects that you see for patients who are on ibrutinib? How will you manage? And what will you consider if this particular fibrillation is bothersome to the patient?
This is probably a case of ibrutinib-induced atrial fibrillation, cardiac arrhythmia. As we can see, there is irregular rhythm with no clearly visible P waves visible on the ECG. So this is a case of atrial fibrillation secondary to ibrutinib, most probably. The other toxicities can be, one is a rash, then myelosuppression, then joint, the other non-specific side effects like joint pain and uh,
So what are the other cardiac toxicities that you see besides atrial fibrillation when patients are on ibrutinib?
it can lead to supraventricular tachycardia. Rarely there can
AF
be
is what?
QT. Sorry, ma'am.
Is it
Pardon.
AF? What?
EF.
What about hypertension? What is the incidence of atrial fibrillation and hypertension for patients whom you have seen on ibrutinib in the OPD?
Very rare, ma'am.
The reported incidence for both is quite high, but I don't know, somehow we don't see that much of atrial fibrillation. Hypertension, yes, many of them already have and are on antihypertensive, so it's difficult to comment. Alok?
Yes, ma'am, I agree with you. Though reported, they say around 10 to 15 and some up to 20%, but we don't see it that commonly. Maybe in 100 patients, 1 to 5, yeah, but even lesser.
What are the other complications, Raghu? You said maybe I have missed it, but I didn't hear bleeding. You said that, right?
Bleeding, bleeding, yes.
Some of them come with bleeding from various sites, especially epistaxis. And so when you call these patients of CLL who are on ibrutinib, what are the tests that you do? See, normally if a lymphoma patient comes otherwise on follow-up, we just do the standard CBC, maybe an LDH or a blood sugar, nothing very much. For a patient on CLL who is getting ibrutinib, what all will you do?
Absolute lymphocyte count has to be checked on the CBC. That is important.
Absolute lymphocyte count in the first 2 or 3 months after you start ibrutinib? So suppose this patient came with, let's say, 60,000 and now it's become 1,20,000 at the end of 2 months. Platelets are not.
This means that there is a resistance, like it's not working because the lymphocyte doubling time is there. So lymphocytes are doubled within 2 months. So it means that this TKI is not working, ma'am. So we have to
Alok, will you agree with that?
This part I have not told. So one thing to remember is that there is a lymphocyte aggression that happens when you start BTK inhibitors. So the lymphocytes will sort of move out of the lymph nodes. So you can have increase in the lymphocyte counts that happens after starting BTK therapy. So which people have said can last up to 6 months, but you most commonly see in the first 3 months. So you should not mistake it for progression. So one of the ways you can clinically look at it is usually if the patient has had nodes or organomegaly, you examine that. If the nodes and organomegaly is subsiding and the counts are increasing, you would think it is just the BTK which is causing the lymphocytosis. On the other hand, if the nodes are also increasing, organomegaly is increasing, no clinical benefit with B symptoms, and the counts are increasing, that is when you would suspect progression. So what you need to be careful, remember this one point. Yeah.
So you actually, the other question I can ask Anand before I put a stamp to it. Do you do the PT-INR often on these patients, especially if their platelet counts is normal?
We don't, ma'am. We don't, because many of them get mild bleeding, but I have not seen somebody coming with a massive bleed or a significant bleed. We don't usually monitor them.
Yeah, so while, in the recommendations, you may find it, we don't really find patients bleeding, just like we don't find too many hypertensives if you're following them up quite regularly and closely. And I think now there is almost 4-5 years of ibrutinib-based therapy. Patients on ibrutinib-based therapy. And except in the initial periods when we have some changes, once they have gone on beyond 1.5 years, the side effects also are very less. Suppose this patient can't tolerate ibrutinib, he continuously has atrial fibrillations. What will you do?
Ma'am, we can change over to another like BTK inhibitor in the form of acalabrutinib.
So is acalabrutinib absolutely devoid of cardiac complications, Alok, or we
No,
can still worry on?
still,
And the newer generation zanubrutinib and the next one, are they even better than acalabrutinib, or they also have a
ma'am,
chance?
the newer BTK inhibitor, pirtobrutinib is supposed to be very cardio safe compared to the earlier ones. Also, zanubrutinib is comparatively safer compared to acalabrutinib and especially ibrutinib.
Yeah, so I guess as the generations go on, we'll get drugs which are safer. Raghu, is ibrutinib available in India now?
Ibrutinib, ma'am.
Yeah,
Yes, yes, ma'am.
you're getting it easily? Okay, that's not academic question. Now we have this 72-year-old gentleman who has been diagnosed as CLL. He has progressed on his BTK inhibitors, and somebody has suggested that he takes venetoclax along with rituximab. So he is progressing and he is under anxiety, like panic attack. And so while he is coming to you for a second opinion and maybe an oncology opinion, on the way, he takes 2 tablets of venetoclax. And by the time he reaches from his gown to the hospital, these are his lab parameters when you have done. So what has happened to this patient?
Developed tumor lysis syndrome, secondary to uh, venetoclax. In sudden, the high dose venetoclax he has taken, and he has developed TLS now currently.
So is there a relationship in CLL according to risk, some kind of risk stratification, which gives us an idea that these patients will develop tumor lysis, and in these patients, they are unlikely to develop tumor lysis? Is there a risk stratification for CLL to predict how severe will be the tumor lysis or on venetoclax? Something to do with the nodes and the total count?
A very bulky nodal mass in the more than 10 centimeter in size, and
Yeah,
total.
you're looking at a large bulk of the disease, whether the counts are very high or whether the nodal size is more than 10 centimeters. Those are the ones who are going to get. So what are the preventive measures you will take when you start patients on venetoclax and rituximab?
One thing is prevention is by proper hydration to be given before starting therapy. At least 3 to 4. So we have to start the patients on allopurinol or febuxostat. Uh, if upfront the uric acid there is hyperuricemia, symptomatic hyperuricemia, then we have to give raspuricase 1.5 mg at least stat and repeat and after another
Any precautions you will take before giving raspuricase to this 72-year-old gentleman?
G6PD deficiency is there, or we have to check. And then for venetoclax, we have to always, as sir told, you have to do a ramp up dosing. Start with low dose 20 mg, and then over 5 weeks, we have to reach the 400 mg mark.
So what are the strengths that are available for venetoclax in India?
100 mg.
So then, Alok, how do we do your ramp up dose?
Okay, like a golden question. All of us are thinking every day. Actually in the West, what is available is 20, 50, 100. We are using cutters and all sorts of jugaad. But yeah, other thing is if you just use 100 mg and maybe give it on alternate days. But again, these are not standard things and things that one is just trying to do. Yeah.
Yeah, that's how jugaad happens with venetoclax, no? So, like AML, you use it with azoles and you don't go beyond, let's say, 100 or 200. What will you do in CLL? Anant, you can take the question.
So, question about ramp up, ma'am.
No, ramp up is
Yeah.
something that is required and we do the jugaads. Is there any way we can use a lesser dose in CLL also with azoles?
Although in AML we have used it with azoles, but in CLL we do not routinely use azoles. But somebody who is not affording, it's a very expensive drug. It can be done. We can use posaconazole to kind of increase the dose of venetoclax and reduce the dose of venetoclax and use it. But that is not something that is recommended. But no, considering the cost considerations, we have done it for a few patients.
Yeah, so this is not for exams, but this is for practice when you have finished your exams. Okay. We have this lady who is diagnosed as CLL. She has bulky disease, and so she's undergone debulking with chemotherapy. And after the third cycle, she presents with a rash and itching. Raghu, which are the drugs that you use in CLL will give you this kind of a picture? And how will you manage this patient?
This is probably a case of bendamustine-induced rash, ma'am. That is typically a maculopapular type of rash affecting the mainly the extremities, and also the trunk also is involved most of the times. And we should stop this drug completely. It cannot be rechallenged. And initially we can manage with antihistaminic drugs, topical topical agents, as well as systemic antihistaminic drugs. And yeah, and
So,
then if
sorry, go on, go on. Finish first, then please.
pardon me,
No, you finish first, then I'll ask.
one it can be managed.
Okay, so Alok, someone who comes with erythematous papillonodular rash, no vesicles, no blisters, nothing. Will you not give them the fourth cycle, or will you still consider something that is, now come down after you have started with the systemic antihistaminic drugs? What will you do? Stop the therapy after 3 cycles, put him onto some other line, or still take this patient forward? Basically, when will you actually decide that definitely you're not going to give any more bendamustine? Anant, you can take the question.
So, bendamustine induced rash, what is typically we don't see it after the first cycle or so. It usually occurs after third cycle, fourth cycle, or sometimes the fag end of treatment. And most of the times, my experience is after a few weeks it goes away. So, sometimes we may have to delay the cycle, but most often it resolves. But with rechallenge, it always comes back. It comes back and it resolves again before we give the next cycle. So if it is not really very discomforting to the patient, it's just a mild rash with just antihistaminics, we are able to control the symptoms. I would generally give the next cycle and not stop bendamustine. But rarely there is it is really very discomforting and severe itching symptoms which just do not go away with antihistaminics, and sometimes they are prolonged, like even after 5 weeks or 6 weeks or sometimes 8 weeks of bendamustine it is not really resolving. That's when I would not re-challenge, especially if somebody is already completed 5 cycle with just one more cycle to do. I would just skip that if it's really severe rash. But if it is mild, maybe after 2 or 3 cycles, I would try to give as much bendamustine cycles as possible.
Yeah, so sometimes you see, vesicles and bullous lesions, which are they ulcerate. So that is a time when you should be absolutely careful and not. Uh, in your experience, how long have you seen patients getting this skin rash, waxing and waning post their 6 cycles of bendamustine.
So it usually lasts for a few months.
Yeah, sometimes actually they have lasted more than a year also. So these patients just keep coming back with the recurrence of this rash. And I don't know, but many people say that those who get this rash actually do better and they have their long-term disease-free survivals as much better. So if you want to, kind of make your patients who are itching all the time happy, you can tell them that they will be better responders than all others. I think with that, we have finished our share of questions. If there is anything else, Alok, Anant, or Pravas, you want to ask Raghu? Raghu has done well. So I leave the other 3 examiners to examine him.
So no questions from my side. I think Raghu has gone through a lot of grilling and he's answered most of the questions.
Yeah, so I think Alok, you took a good lecture and Raghu answered all the questions. So I guess today's Gurukul is okay. Pravas, you can give us your last comments and then we'll wind up.
So ma'am, there are few questions in the chat box about CLL. Maybe we can just take a few, one or two.
Yeah,
So,
go ahead.
So there are 2 questions on CLL and TLS. So Alok, one is why is chance of TLS more in CLL and why is ramp up slower in CLL compared to AML? Do you want to take that question?
Put a sort of center. So I think mainly because once the burden of tumor cells is much higher in CLL compared to AML when you're seeing, and the activity of this venetoclax in terms of this BCL2 inhibition would be much more in CLL and the neoplastic cells compared to AML. So I would say one is the burden of the neoplastic cells that are there. I mean, you have the lymphocytes everywhere compared to AML, where it's mainly in the bone marrow. And the activity with respect to this BCL2 inhibition on all these neoplastic cells would be much more, and the cell kill would be much more compared to in AML. If anything you have to add, sir.
Yeah, I would agree with that. Uh, Basically, the sensitivity of the CLL cells to BCL2 inhibitor, since BCL2 is the driver mutation, is the most important driving force in CLL. Certain AML subsets like IDH2 mutated AML are also very, very sensitive to venetoclax. And in these patients also, you will see that these patients are at a higher risk of TLS. So basically, because the sensitivity of the cells to BCL2 inhibition is what drives the TLS. Let's see, there's one more question, and this is from Dylan. In emergency, can we avoid G6PD testing before raspberry case?
Yeah. So, Dylan, yeah, we can avoid. At least if you're using like this low dose raspberry case, like what most of us are doing, you can avoid because usually the hemolysis is little controlled and resolves on its own. So I mean, that's why we are not routinely doing it, but it's a good practice to do. But usually the hemolysis, if it does happen, is usually reversible. It does go up sometimes too. The bilirubin goes up, but it then resolves within time. So it's managed.
So all the G6PDs that I have done, I have never really found anything which worried me. So I don't know why they say the incidence is more in men, and so you must do it. But that is the recommendation of the books. Raghu, anything on vaccinations for ALL and CLL in particular?
For CLL, ideally it should be done for both, but for CLL, especially initially, if there is no indication for treatment, then ideally we have to vaccinate the patients upfront. One is with influenza vaccine, then a pneumococcal vaccine, and the hepatitis B vaccination, and the Shingrix vaccine. These are the bare minimum that we have to
So if
vaccinate.
you have a patient under watch and wait, will you give the hepatitis B vaccination to this patient? I'll ask Anant and Alok what they do in practice. I don't, so that's why I want somebody to.
Sorry, I'm saying hepatitis B vaccination.
If the patient is under watch and wait, we will recommend influenza and pneumonia for certain. But will you also give hepatitis vaccinations to this patient?
One can consider, I mean, if they've not previously vaccinated, I mean, one way to look at it is anti-HBs titers. I have not routinely done it, but I think one can consider. Yeah.
And what is your
we
opinion on giving shingles vaccination to these patients who are not on treatment yet?
Yeah.
I'm confused, so that's why I'm asking you.
I think it's more and more creeping into geriatric vaccinations in general. So can consider. I mean, the one challenge with shingles I felt is one is the cost. But if zoster does occur, it's very painful for a lot of patients. So I would say it's a good practice to consider. But major challenge becomes cost actually.
Anant, any
Ma'am,
more
if we are
questions?
if we are using assevere prophylaxis, then the many of the risk of reactivation is very low. So if we are using assevere, then maybe we can we need not use the vaccination, especially if that's because it's so costly. And no, obviously if the patient is affording, then we would vaccinate. We don't usually routinely recommend it in our practice, but we do add assevere prophylaxis. So with that, we don't see as much of herpes reactivation.
So this was, particularly for those whom we keep as watch and wait. I would not, I mean, the elderly would be at risk of renal dysfunction with assevere. So there is a problem whether we should give all of them or we should still take a call when costs come down. Yeah, I think vaccination is important, especially even if you're not treating these patients, they need to be vaccinated because otherwise they come with repeated chest infections. And some of them actually don't have problems from CLL, but from the infections that they get. Anant, any more questions from in the QA?
One
Most of
who's asked repeatedly, I think his questions is stressed out about all the different protocols. So I would just like to say that we, Dr. Ronak, if you're there, so don't stress out. There are definitely different protocols and each have their own nomenclature. But the general principle, you'll realize that it's the same drugs which are mixed in a different way. Actually, if you even look at it, even CHOP is basically the same drugs which are utilized in different doses. So it's you may probably not have to remember each protocol. How is it in each? How it's little different in each protocol. Just be comfortable with the protocol that you're using most commonly. The general principle, like at least because we are using the BFM most commonly in AYA, and which is very similar to the pediatric icicle protocols also. In induction, you have to just remember it's weekly VCR and daunorubicin, and every 3 days you give L-asparginase. So that is done. Then in the second part, where you're giving consolidation, you're just using a different set of drugs, which is 6-mercaptopurine and cytarabine with 2 doses of cyclophosphamide. That's it. And then an interim 1 high-dose methotrexate phase. What you can remember that in delayed intensification and re-intensification, it's the same drugs which come in with slightly lesser doses and with certain changes to, to mitigate some toxicities. For example, in re-intensification or delayed intensification, the prednisolone becomes dexamethasone. Then because, many times utilizing dexamethasone in induction can be a nightmare. So the prednisolone becomes dexamethasone. The daunorubicin, VCR daunorubicin becomes VCR doxorubicin, mainly because, like I said before, daunorubicin has little lesser incidence of mucositis, which could be difficult in induction. L-asparginase, it's like if one has used 8 doses of conventional L-asparginase in induction, you use 4 doses. So that's the main difference. And again, instead of 4 pulses, one give 2 pulses. So, I mean, that's the general principle. It is not so much to do with half-lives. It is just like dose-dense therapy in breast or anywhere. You're basically giving dose-dense therapy where you're giving weekly injections. So that's what you need to remember. Based on this, again, like if you take hyper CVAD, if you take GMOL, It is all the same, where you have different drugs which are used in different doses. And there should be some element of CNS prophylaxis throughout the procedure. So I think you shouldn't stress out too much on nitty-gritties of each protocol. If whatever you're using, as long as you're comfortable using it and use it properly, I think that will be the best. I mean, sir, ma'am, anything you want to add?
I just want to say that there is a tendency, to pick up induction from one protocol, consolidation from another, and maintenance from a third one. Avoid that. The one which you decide to follow it with all, what should I say, with all faith in the protocol. The other thing that I'll ask you, Alok, now that you said this, do you give vincristine and dexamethasone as part of your maintenance still, or is that completely gone now? It's only 6-MP and MTX. And is there any role of 3-monthly IT methotrexates in maintenance? This is
Yeah.
something that happens in many protocols all across. So
No, ma'am, as part of the BFM, at least we are not giving this, either intrathecal or the vincristine dexa pulses that come in maintenance. So only 6-mercaptopurine and methotrexate.
So very often, you see protocols which have been matched, and then these things creep up in the protocol. So just follow the one that you would like to follow and go ahead with it. So we call it a day. It's 4 o'clock.
Sunday afternoon.
Yes. Raghu, you have to say anything. How can we improve the teaching sessions?
Ma'am, it was a very good experience, ma'am, and helped me also to brush up all my the concepts, and it will be very helpful for each and every one of us. So yes, ma'am.
So I like the
Yeah.
students in India. They never criticize their teachers. So I think Anant, Alok, and myself can go happily today. Okay. Thank you so much.
Thank you,
Thank
Alok,
you.
for the
Thank you.
wonderful talk, and thank you, organizers.
Thank you so much, sir. Anand, sir, if you could just give a take-home message for everyone out there.
So, take-home message would be to remember the common toxicities and do the simple things. If patient is, look out for the symptoms, take a good history, ensure that there's good hydration, and just cover the basics. Don't have to really mug up all the drugs. When you always remember that the common toxicities should be avoided, and the uncommon ones, the rare ones, you can never really preempt, and we'll have you can really never really preempt them, but the common ones you can preempt, and you can kind of prevent those from happening. So adequate hydration, good hygiene, treat with antibiotics with the first sign of fever in neutropenic patients. Ensure that the patients are counseled properly, that they have to come to the doctor immediately if they have any signs of sickness or any symptoms of fever. So these are the basic things that need to be covered. And if you remember those, I mean, you will be safe in most of our patients.
Thank you so much, sir. So with that, I would like to, thank Dr. Alok Shetty for being the esteemed speaker and delivering such an insightful and in-depth session. I think you've covered you've touched upon almost everything, and the discussion that happened after that was truly amazing, because I think most of these setups in India do not have a dedicated hematology OPD along with the medical oncology setup. So for people who are from the medical oncology background, this was actually truly insightful. And a special thank you to Anand sir. I mean, you steered the conversation so effectively, and I mean, it was really nice to have you, and especially Reena ma'am. The discussions were amazing, and I think all of us learned a lot of new things. And last but not the least, I would also like to thank Dr. Raghu for being the examinee and doing his due diligence and sharing everything on spot. So with that, thank you so much. And I would also like to invite you for the next session that we have on lymphoma. So that will be on 13th of April. And we have again exciting examiners and moderators in Dr. Gaurav Prakash sir, Dr. TVS Tilak sir. We have Dr. Lingaraj sir. Also, our speaker is again a young dynamic speaker, Dr. Faheema Hasan, and we also have Dr. Stalin Bala, who will be the subject mentor. So I request all of you to tune in again next Sunday from 2 to 4. And I will also request any of the residents who wants to be an examinee, do message and tag along with rest of the examinees. With that, I would like to end the session. Thank you so much. Thank you, sir.